be talking about infection control and how we got where we are. I'm from Rush University Medical Center, Cook County Hospital, Chicago. I have 10 topics for today, and the first is how we got where we are. Long ago, healthcare providers recognized that infectious diseases, although then they didn't really know they were infections, they were just diseases, could be spread from person to person. And this is an example of a healthcare provider in the plague era, when we saw that they wore gowns like we do now, masks like we do now. That little beak was for perfume so that the odor of decaying bodies wouldn't offend the healthcare provider. A jaunty hat. They had a stick that they used to prod patients to see if they were still alive. These days we don't use a stick, we use intern. Fast forward almost 2 centuries ago to the 1800s, and you can see the major insights that were developed then by Charles Darwin, who developed the concept of survival of the fittest, described the origin of the species, and by Ignaz Semmelweis, who was an obstetrician in Vienna, who showed that childbed fever, puerperal sepsis, was spread on the uncleaned hands of prosectors who moved from the autopsy table to OB wards, and led really to the first recognition of the germ theory. Fast forward again, and we're now in the era of the most recent nosocomial pathogen. You can review this as actually 4 eras. The first is streptococcal infection, which were in the early 20s to the 50s, rheumatic fever and so forth, followed by staph infections, which caused pandemic infections in newborn nurseries all around the world. And then as introduction of chemotherapy and steroids became prominent in hospitals, we started to see gram-negative infections, Pseudomonas aeruginosa being the quintessential gram-negative. And now we're in the era of MDROs, or multi-drug-resistant organisms, methicillin-resistant Staph aureus, vancomycin-resistant enterococci, bugs with extended spectrum beta-lactamases, carbapenem-resistant Enterobacteriaceae, Clostridium difficile, Candida auris, and even vancomycin resistant. How have we gotten here? How have we allowed this to happen, to unfold? What is the problem? Well, here is a skeptical view. When the situation was manageable, that is, before we had all these resistant organisms, the problems were often neglected. And now it is thoroughly out of hand. We apply too late the remedies which then might have affected a cure. There's nothing new in this story. It falls into the confirmed unteachability of mankind. Want of foresight and willingness to act when action would be simple and effective, lack of clear thinking, confusion of counsel until the emergency comes. These are the features which constitute the endless repetition of history. This is a quote from Winston Churchill in 1935, before the dawn of World War II, but it's as applicable to our lack of control of multi-drug resistant organisms. We just haven't acted soon enough or fast enough. So what could we do to be better at controlling? Well, I want to talk about key epidemiologic features in general. The major driver of transmission of pathogens in hospitals is uncleaned hands of healthcare workers, spread them person to person. And I've superimposed this on what I call the resistance iceberg. And I call it a resistance iceberg because the part that shows where the hand is represents clinical infections that we recognize. But beneath the surface are patients who are colonized extensively with multi-drug resistant organisms that serve as the reservoir and a risk factor for spread in hospitals. And you can see of 2 concepts that are key in the resistance iceberg are the fecal patina, that is, interestingly, the gram-negative bugs and gram-positive bugs that are resistant coat the skin of patients in hospitals. So they're like microbiologic chameleons, that they develop a skin flora that reflects their environment of resistant bacteria. And the more of these patients there are, the greater the colonization pressure, which is the second concept, which leads to spread from person to person. And you can see there are 2 circuits here. On the right side, as you're looking at the screen, is the in-hospital circuit where bugs are spread from ward to ward, environmental contamination, food sometimes contaminated, and importantly, antibiotic pressure. And on the left side is the circuit outside the hospital of patients who are readmitted, transferred to other hospitals, and importantly come in from nursing homes, long-term care facilities, where they may be colonized with resistant organisms and bring them back into the hospital. The other aspect, besides hand transmission in general, is transmission by airborne pathogen. And this was proven a number of years ago in an elegant experiment you can see on the left-hand side, where a series of animals were placed above the room of a patient who had infectious pulmonary TB, and the air from that patient's room was circulated up to the animals, and the animals developed tuberculosis, proving the airborne possibility of transmission of TB. So what can we do to control these problems? I want to talk about general control measures and then drill down on more specific control measures, including surgical site and device-related effects. For the general control measures, probably hand hygiene is the most important of the general control measure. And there's actually wasn't one controlled trial, at least that I could find, of hand hygiene in which newborn nursery nurses were relegated either to clean their hands between every patient or not clean their hands. And cleaning hands between patient contacts and newborn contacts showed about a 50% reduction in spread of pathogens within the newborn nurse. To understand the most effective interventions, I think it's helpful to look at the causal pathway. That is, how do multi-drug resistant organisms spread in hospital? This is a causal pathway, and you can see people come in with a normal flora, and then 10 or 40%, depending on the study and the population, when exposed to antibiotics, when exposed to people in the hospital who have carry multi-drug resistant organisms, and as a colonization pressure, exposed to a number of other factors, there's multi-drug resistant colonization occurs. And as I said before, virtually 100% of these patients pick up antibiotic resistant drug, develop this fecal patina of skin colonization, and often gastrointestinal and respiratory carriage. Up to 20% then contaminate their environment, up to 40% or more contaminate the healthcare workers' hands of healthcare workers. If the healthcare workers don't clean their hands, they lead to patient cross-colonization, and then depending on the devices and the exposures of the patients may or may not become infected. How have we dealt with this causal pathway? Well, interestingly, we've started at the very far end of, we have device guidelines, that is, treat devices, vascular catheters, ventilators, and so forth, in a way to decrease risk of infection, report rates of infection, look for clusters of infection so that we can do investigation. We move up the causal pathway. Hand hygiene becomes important for some pathogens. We screen patients when they come in the hospital. There are isolation precautions if they're found to be positive, and again, cluster detection. Hand hygiene to lessen the chance of spread on healthcare worker hands, and universal gloving, that is, putting on examination gloves that are disposable between patient contact. Moving up the causal pathway, improved cleaning, and then as we move closer to the beginning of the causal pathway, because the better we are at intervening early in the pathway, the less patients will progress down the pathway. Chlorhexidine bathing has been shown to reduce and eliminate fecal patina, leading to decreased risk of healthcare worker hand contamination and decreased patient infection. And then finally, at the very top of the pathway, if we do better with antibiotic use, and as we'll talk later, restore the microbiome to eliminate colonization with multi-drug resistant organisms, and then there are other situations that may arise, we may be able to intervene at the very top of the causal pathway and prevent this transmission from occurring. There's also been increased interest in the environment. As you could see on the previous slide, the environment is a risk factor, and I want to show here what I think are two key environmental concepts. The first is the introduction of indoor plumbing. Indoor plumbing and water sanitation have probably done more for the health of the world than any other intervention. And the second is the concept that just because a pathogen is found in the environment doesn't mean that it is a problem. And so this pathway diagram shows that, this flow diagram shows that not only do you have to find the bug in the environment, but you have to show that it gets transmitted to patients from the environment, and that eliminating the pathogen from the environment reduces infection risk. So those are key concepts in the study of the environment. And this is an example of the environment. There's new interest in waterborne pathogen, and this is an outbreak that looked at sink traps, which were an interest maybe 60 or 70 years ago, and have become an interest again as people have recognized that occasionally sink traps can be contaminated with multi-drug resistant organisms as a source of infection, particularly in intensive care. And then the final aspect of kind of overall measures is antibiotic stewardship. And this diagram from the United States shows something that's somewhat troubling. That is, there's almost a twofold or greater difference from one state to another in the use of antibiotics. And there isn't that much of a difference in the risk of bacterial infections. And so we know there's a long way we need to go to reduce the overuse, profligate use of antibiotics. We'll talk. So now to get to more, drill down to more, from general measures to more specific measures. And the first of the specific measures I want to talk about is surgical site infection. So in addition to good surgical technique, which is probably the most important thing to prevent a surgical site infection is careful choice of your surgeon. The surgeons are really critical in this. And then in addition, there are a number of things that are done in the surgical suite to reduce infection. There's prophylactic antibiotics, which are started shortly before surgery and stopped shortly after surgery. There's no evidence of starting them early or continuing them longer make a difference. There's appropriate hair removal, avoiding razors, nick the skin, and the little blood that results from nicks allows bacteria to grow, so we avoid razors now. Surgical site skin prep has been somewhat controversial recent, whether to use an iodophor alcohol, chlorhexidine alcohol, depends on the specific product. And then there are a number of interventions that have been shown in specific subsets of patients. So in colorectal surgery patients, perioperative normothermia lessens risk of infection, and there's a basis for that on white blood cells working better during normothermia than during the reduced temperatures that patients often have during surgery. Maintaining glucose control has been shown to help reduce risk for cardiac surgery patients. Supplemental perioperative oxygen, again, possibly making white blood cells more effective. Some studies have shown that nasal decolonization of Staph aureus, particularly in patients who are having implanted devices like orthopedic procedures or cardiac procedures. Using checklists to make sure that all of the interventions are carried out. And then interestingly, reporting of rates. If you tell a surgeon his or her infection rate and the rates of others in general, the surgeons will reduce their infection rate. So they're doing things that they know they can do better, and by comparing them to their peers, they will do better. On this list are not two things that have been controversial in the past. One is laminar airflow technology, particularly for orthopedic procedures. Another is use of UV lights in ORs, which neither of those have been shown consistently to be effective. So to drill down further on device-associated infections, I want to look at devices, and I want to look at a couple devices. Particularly, I'm going to look at ventilator-associated devices and vascular access-associated devices. But the first question, I think, that we have to ask ourselves is the basic question for device-related infection. Do we need technology to trump bad behavior? That is it easier to improve human behavior and to improve their attention to hygiene and asepsis, or is it better to design a more foolproof device that is not contaminated? Well, the first example of this question is an early lesson that we learned during the introduction of ventilators for ventilating patients in intensive care units. And the introduction of ventilators was followed soon by outbreaks of necrotizing pneumonia, and it became clear that the equipment that was used to ventilate patients was not being disinfected adequately between patients, would lead to high bacterial counts in the equipment. The bacterial counts would be transmitted through the tubing into the patient's respiratory tract. So we learned that we had to improve the equipment, but we also had to improve the attention of healthcare workers to disinfecting the equipment. A second example is the duodenoscope, which is a major advance in gastroenterology, but it's been associated with multiple outbreaks of bacteremia because the distal end of the duodenoscope is very, very hard to decontaminate, to sterilize. And if it's left with a few bacteria, they can be introduced into the GI tract with occasionally disastrous consequence. This is a good example of where we need both a better device, more easily disinfected, and better attention by personnel to disinfect it. And then the third type of device-related infection I want to show is a major win. We have done in Infection Control a tremendous job for reducing the risk of infection due to vascular access catheter. And I think it's based largely on our understanding of the pathophysiology of the infection. We know that many of the infections come from the skin flora, from these bacteria, and how important it is to decontaminate this, and that the catheter hubs can be contaminated, and then very rarely the fluid can be contaminated. So we know to focus on the devices and on the device-skin interaction. And this has led to an ensemble, that is a group of interventions that are bundled together. This is from the CDC's Healthcare Infection Control Practices Advisory Committee, IV Guideline Prevention Ensemble. 5 things to do: educate personnel, remove catheters that are no longer needed, avoid changing the central lines as an infection control strategy. It used to be common to replace the central line every 4 days over a wire. We've now learned that that's a risk, not a benefit. Prep the skin site with chlorhexidine or another very, very active agent, and wear gowns and gloves when putting in the catheters. And if you do these 5 interventions, each of them has been demonstrated by a randomized controlled trial to be effective, you markedly reduce risk of infection. And then some people use antimicrobial or anti-infective coated catheter. Although even without those, you can reduce infection rates almost to zero. The most recent iteration of this ensemble is shown here. Many, many, many more aspects to it. An interesting issue is that the contribution of the individual aspects to the ensemble is not known. So do we have to do all these, or just if we just wear maximum barrier precautions and prep the site, those two interventions, are they enough? And we really don't know, and that needs to be figured out because these interventions may become overwhelming. So the big question is, which of these aspects of the ensemble is truly essential? The next topic is quality improvement, and I'm actually not going to comment on this because you're going to hear an excellent talk by Dr. Susan Casey on quality improvement. So I want to move on to lessons from outbreak. So I'm going to talk about a series of 5 pandemics, and the first is the flu pandemic, which was devastating in 1918-19, affecting about a third of the U.S. population. Importantly, this pandemic demonstrated the risk of introducing a new pathogen into a population that was totally susceptible. So H1N1 had not been around recent years before this pandemic. The entire globe was susceptible and led to the pandemic. Sound familiar? And also, this pandemic really provided key lessons for subsequent pandemics about the value of what's called non-pharmacologic interventions, such as masking. The Legionella outbreak introduced a newly recognized pathogenic threat, and interestingly and importantly, this was not spread person to person. That was a key finding early on, and is due to environmental contamination. So it's a good example of how the environment can be a real problem. Third example is, of course, HIV/AIDS, which has changed the blood transfusion and sex-borne pathogen risk for all ages, for all time to come. It's been a major change in the way we see bloodborne pathogens and sexually transmitted diseases. Many, many ways it's affected. The Ebola outbreak led to an important reevaluation of personal protective equipment, or PPE, masking, gowning, gloving, etc. This outbreak really led to an important understanding of donning and doffing of protective equipment. And then the last and most recent pandemic is that of SARS-CoV-2, which causes COVID-19 infection. And I just wanted to go through a number of lessons we've learned just very, very recently. The first is that animal pathogens can cause a major threat to humans, especially if they're re-engineered. And we still don't know whether the SARS-CoV-2 is totally from the environment or is partially re-engineered. We also learned that a remote problem can become a global problem in just days or weeks. We saw that the clinical and epidemiologic histories were powerful tools. That is, if a patient showed up with respiratory infections and complained of loss of smell or taste, it was pretty good evidence that that patient probably had COVID-19. We learned that transparency and cooperation, and we learned this again and again with every pandemic, are essential. Countries have to cooperate. We saw the unbelievable economic consequences of shutdowns, and this, I think, will change how we view shutdowns going forward. I think we will not be as aggressive with shutting down the economy for the next pandemic. We learned that advances in molecular virology and diagnostics have been unbelievably impressive. I say, wow. And this pandemic really opened a re-understanding of what in the past was a dichotomy between droplet spread and aerosol spread. And we now learned it's not one or either, but a continuum from droplets through aerosol. We learned that basic control measures work very, very well, but are unforgiving to lapse. If there are lapses, the outbreaks come back. And then there are 4 aspects that are key for optimizing infection control. We learned that again and again. We have to know the reservoirs and sources. 1, we have to know the mechanisms of spread. 2, how much is airborne and how much is droplet and how much is in the continuum. What is the incubation period of the pathogen, and the reproductive number, that is, how many secondary cases are there from each primary case. These are all important in understanding infection control. We did an unbelievably impressive job worldwide in developing vaccines and even antiviral. And then finally, we learned that travel can have a huge impact. Let me just play a little song from the Capitol Steps to show you how travel can have an impact.
All my bags were packed in the overhead bin. The guy sitting next to me flashed a grin. We buckled up and both got set to go. And then suddenly as we took off, that guy began to shake and cough. It worried me that he was in my row. I said, don't kiss me or smile at me. I wish you were a mile from me. Could we put you in the hold below? You brought TB be on a jet plane, and it's a drug-resistant strain. How could they let you go? Your new daddy works for the CDC, and he said it's all right by me. Don't worry, go and have your wedding day. But nobody dreamed the gift you brung would get on board inside your lung, and TSA took my Purell away. So they'll frisk me and x-ray me, and now they'll want a biopsy. Next time that I take a plane, I'll know that it's safer to sit next to a bearded guy who lights his shoe. But run if it's his nose he starts to blow.
And now I'd like to talk about 3 of the newest advances in how we do infection control: statistics and modeling, molecular advances in the microbiome. And the first of these, I want to talk about statistics and modeling. Now, that could be a whole additional lecture. So I just want to give you a caution rather than go into a full lecture on this. And the caution is this. This is a patient being wheeled up on a gurney, and he says he's the sign outside the hospital. You know, hospitals like to advertise now, tested the best, good choice hospital with low infection rate after surgery. And the patient says, see, this is where I should go. And then the attendant who's wheeling him in gives him a caution about how you interpret statistics. He says, yeah, but there's a slight drawback. Most patients here do not survive surgery to get infected. So you have to be careful with statistics and modeling. The second of the 3 advances I want to talk about is molecular advances, which are in diagnostics and therapeutics. And they really were ushered in by our understanding of DNA. And this is a slide from Watson and Crick. It was, interestingly, 1.5 pages that demonstrated the structure of DNA that led to all the changes downstream in molecular diagnostics and therapeutics. As an example of how we've harnessed this molecular genetic understanding, I want to show you this outbreak at the National Institutes of Health, the NIH in the United States. This is an outbreak of carbapenem-resistant Klebsiella. And when they started the outbreak and tried to do epidemiologic mapping, this looked like a bowl of spaghetti. They really couldn't understand the spread from person to person. And when they applied whole genome sequencing, they were able to unravel this spaghetti and show and clarify the routes of transmission remarkable. And we've learned that whole genome sequencing, or WGS, has improved our understanding of many, many different pathogens. So this is really a very, very important molecular technique and a great advance. And then the third and last topic for today is the relation of our microbiome to all that we do and are. And this is an example of the Human Microbiome Project from the NIH that remarkably increased our understanding of how our flora, that is our microbiomes, influence many, many, many diseases. So not only does it influence malnutrition and intestinal metabolism, but it influences cardiac risk, diabetes risk, all sorts of. And this has actually led to an important intervention. That is, if we can change the microbiome, that is, if people come in the hospital with recurrent Clostridium difficile infection and we can eliminate the C. difficile from their gastrointestinal tract, we can reduce their risk of infection. And there's actually thought about using the microbiome to reduce risk of MDROs. That is, if people have a gut colonization of multi-drug resistant organisms, if we can give them healthy bacteria and get rid of the microbiome of resistant bacteria, we can change their risk of infection by those resistant bugs. Interestingly, this is not a new concept. Microbiome manipulation goes back at least 60 or 70 years, and you can see in the upper left-hand side, there was a use of bacterial interference, they called it then, to control a staph outbreak in a nursery. They tried to decolonize people by deliberately colonizing them with an avirulent strain of Staph aureus. They got rid of the virulent strains, but unfortunately the avirulent strain became virulent, so that didn't work out so well. And here's another example of using alpha strep, avirulent alpha strep, to try to decolonize newborns in a nursery to get rid of Klebsiella and other gram-negatives. And this is a very interesting book you might want to read. And in this book from 50 or 60 years ago, William Nolan, a surgeon, describes how one of the interns in his group had a patient who had postoperative colitis, probably was C. difficile, but people didn't know about C. difficile at the time. And the intern kind of rationalized or realized or hypothesized that, well, maybe this person has a bad bug in their gastrointestinal tract, and if I give them good bugs, it'll get rid of the bad bug. So the intern mixed some stool up in some chocolate milk and gave the patient a chocolate fecal milkshake, which reduced and eliminated the colonization with the bad bug, as the intern had hypothesized, and cured the patient. Fortunately, the intern got fired for doing it in an uncontrolled manner. So I want to conclude with what's next, and I want to make 6 predictions. There have been dramatic advances in infection control and advances in informatics and AI and new devices will impact infection control at all levels. And I view this as kind of Chat GPT meets Star Trek. So we're going to see all sorts of amazing things in the future. Related to this, possible that disposable instruments may avoid some of the disinfection problems, but they may bring their own issue. A third prediction is that molecular level understanding will continue to expand in diagnostics and epidemiology, our ability to detect, control, and predict outbreaks. And as we've talked a little bit about microbiome manipulation, people are doing it now for C. difficile. People are beginning to study this to rid patients of multi-drug resistant organisms. I think essential to this is careful study of the interaction of the different components of the microbiome. That is, the GI tract has a microbiome, the skin has a microbiome, and women, the vagina has a microbiome, there's an oropharyngeal microbiome. How do these interact and affect each other? And if you just interact with one of the sources of the microbiome and intervene with one of the sources, how will that affect the other aspects of the microbiome on the skin or the vagina? Fourth, I think this is essential. Fourth, I think we'll resolve, again, the droplet aerosol dichotomy and understand better the continuum between droplets and aerosol. Fifth, I think we really need to improve antibiotic utilization. We need real-time national and international data, and we are beginning to see alternative therapies to antibiotics. There's phage therapy, and there may be other alternatives that will come around. And then finally, I think long-term care needs much more attention. And in all of these aspects, it is essential that we do whatever is achievable while we push for the aspiration. And with that, I'd like to thank you for all that you do, for all that you do for infection control.
I'm still up very late at night in Chicago. It's good to see you, sir. And really appreciate you taking the time and staying up so late for us.
Okay. I think we're back on time now, but if there are 1 or 2 questions, I'd be glad to take them if you can hear me.
So, anybody have questions for Dr. Weinstein? So I do have one question, Dr. Weinstein. I've been plagued by this little problem that people have this unbelievable urge and belief in the potency of antimicrobials, what I call pesticides. And I've been unable to wean them off. And even when I have a diagnosis and I've seen the patient and I've told them what's going on, and here's the narrow spectrum specific antimicrobial that will suffice, and they still want to use gorillamycin. They don't seem to care about the spread of these organisms to anybody else. And I'm not sure that that's necessarily unique to India. I see the same problem in the United States. So, and how do we cure people of this kind of addiction? And then add to it that very often people have a very reductionist approach to what is an infection, how to prevent it, how to cure it, and so on and so forth. How do we make people understand that it's really not that very straightforward and simple? There are just too many factors. It's a complex adaptive system.
Yeah, you're talking about a problem that's been going on for since the introduction of antimicrobials. There have been papers about this, and there have been commissions and white papers and programs and plans. And as you say, they've all, kind of like Winston Churchill said, come to naught. I think there are 2 aspects of this. One is people want to do the right thing. And if you ask an audience of practitioners, how many of you think antibiotics are a cause of resistance and a problem. They all raise their hand. You ask them, are you prescribing in a way that would cause a problem? None of them raise their hands. And if you say, is the person next to you giving antibiotics in a way that's causing a problem, they all raise their hand again. So they all think that they're doing it right and that someone else is the cause of the problem. So I think you have to take a step back. And at the time people order antibiotics, I think the most effective intervention that I've seen is computer provider order entry, CPOE. So you go to order an antibiotic, you'd have to do it through a computer, and the computer says to you, this patient has less than 1% chance of a resistant bacteria. You should be using cefazolin, not imipenem. And there's a series of papers that have come out in the New England Journal by Susan Huang, and there's papers in JAMA by Shruti Gohil. And I think the JAMA papers, there are 4 of them, 2 have come out already. They've looked at using computer provider order entry for treating UTIs, skin infections, intra-abdominal infections, and pneumonias. And they've all shown that by having computer provider order entry, you can markedly decrease the use of broad-spectrum antibiotics. So I think at least that's a start, I think, to use the newer technology. Years ago, when I was at Michael Reese Hospital, which, as you know, was in Chicago, blessed memory, it doesn't exist anymore, we actually had a computer provider order entry system in the 80s. It was one of the informatics people there figured it out. And we were able to direct therapy. When tobramycin came out and was much more expensive than gentamicin, we were able to say there are only 4 indications for tobramycin if someone ordered it. And if your patient doesn't have one of these 4 indications, please go to gentamicin. And something about the interaction of people with the computer, they're not threatened. They take it as kind of a neutral educational source. It's not like their ego is affected because they're not talking to another person. It's just the machine giving them some advice. And people really paid attention, and we reduced tobramycin use by 90%. So my answer would be computers.
Should not only be experts at ChatGPT and Star Trek and, become Jedis, but we must also learn human factors engineering.
Yeah, I think a lot of times we have to trump human factors and go directly to the technology because, it takes a long time for people to change their behavior.
Right.
Decades.
Once again, thank you very much, Dr. Weinstein, and have a good night. 1 second, there's one more question.
Thank you for that very illuminating talk. Though out of the context of AMR, my question to you is based on a recent information regarding Parkinson's and the microbiome theory. Earlier it was believed brain first, gut later. But now the more recent one, very recent paper, talks about gut microbiome and the gut first related to the brain later kind of affectation in Parkinson. Having said that, do you think there would be, I don't know, it's just imagining now, because we're talking so much about AMR, that the gut microbiome of a person who has maybe a load of resistomes as against another person with a gut microbiome with maybe hardly any resistomes would be a good thing to study in Parkinson's if at all we want to look at the gut first, brain first, later theory?
Yeah, I think that's a very interesting question, that the gut microbiome we know affects the immune axis. We know it affects very, very many things. And there's this gut immune central nervous system axis. And so exactly as you're saying, people have begun to look at it. It's something to study. We're looking at it now in terms of COVID and whether the gut and the gut microbiome affects the immune axis in such a way that leads to long COVID, or at least for some of the patients. So yeah, I think people will look at it. It definitely is an area to be studied. Whether it'll turn out to be correct or not, I don't know. But for years, dentists and oral surgeons have said that if you have bad gums, your risk of heart disease is much more. And we know that bad gums cause inflammation, and inflammation causes plaques in the coronary arteries to destabilize. And so people who have bad gums, pyorrhea, and so forth have a higher incidence of coronary infarctions. So I think there's no question that the microbiome interactions are much more than we think they are. You know, some people used to say you are what you eat, and I guess this is an example of you are what you eat. So yeah, I think it's something worth looking at. Whether it'll turn out, you know, a lot of these things, the pendulum swings. No one's interested, then everybody's interested, and then eventually it comes to some place in the middle. So, but I think it is an important thing to study, and thank you for bringing it up.
Thank you.
Thank you, Doctor, staying up for night. I won't be taxing much of your time. I have a simple yet complex question that do we see a life beyond colistin? Because it's been a while since the highest antibiotic has been discovered. So how do we see, is the life promising beyond colistin?
So you want to know if new antibiotics will be coming out?
Yes, yes.
You know, the profit motive is very, very, very strong. The pharmaceutical industry has lots and lots of very smart people. So I think there will be new drugs. I think, though, that the way new drugs are discovered is going to change, and it'll be directed more at designing drugs rather than looking in the environment for, you know, the way cephalosporins were found in the soil in Sardinia or whatever the story was. So I think the new drugs will be more engineered. But yes, I think there will be new drugs. It takes a long, you know, the pharmaceutical industry always points out it takes a very, very long time to make drugs, and that's why they charge so much money for them. You know, I don't know the economics of it. I know what's said. So, but to answer your question simply, yes, there'll be more drugs.
Thank you. Thank you, Doctor.
Thank you, Doctor, for your enlightened lecture. As we come to the new drugs, do you believe in antimicrobial peptides from natural sources? Would be this natural outcome come over the what antibiotics are available in the market nowadays and compact it in the nearby future if we come over the hurdle of it? Thank you.
I'm not sure I totally understood the question, but if you're asking about naturally occurring antibiotics, I think there'll be less of those and more antibiotics that will be engineered by computers or people using computer programs to design antibiotics based on the targets that they're trying to hit.
Okay, so thank you very much once again, Dr. Weinstein, and please have a good night. Thank you. Thank you for staying.
Thank you. Enjoy the rest of the conference.
Thank you.